Okay, everyone, I think we'll get started. More people will hopefully be joining us as we go. My name is Laura Hines. I'm in the Mass General Cancer Center. I'm pleased to be part of this group presenting this webinar today. We're doing this in conjunction with the John Estrella Foundation for Cancer Research. So I'm going to introduce Alicia in a few minutes to talk about that organization and give you some more introduction to the evening tonight. As you might have noticed, you're in listen only mode. So this is a webinar. So you won't be able to speak or turn your camera on because we want to really make it so that we can record this session and make sure everybody remains anonymous. But we really do want to encourage participation. So please note that at the bottom of your screen, you should have the Q&A function. And we invite you to please ask as many questions as you like to the presenters. Only the presenters will be able to see them. And if you want to remain anonymous, even to the presenters, you can click that box and just remain an anonymous question asker. But we hope during the sessions, you feel free to go ahead and ask questions using that feature. And then at the end of the presentations, we'll have a whole question and answer session and go back and forth with the speakers to get a lot of those topics covered. So we encourage you to do that. In addition, if you just want to share some thoughts about the conference or kind of with the community, I know it's harder not being in person to create this community. We do have the chat box open as well. So feel free to put anything that you want into the chat box, share any comments. We just ask that you please don't put any personal information in there, any medical information. If you have a medical question, please refer to your doctor, your medical team. But we encourage you to comment in there and also to make sure you put the questions in the Q&A that you would like the speakers to address at the end of the sessions. As I mentioned, the conference is being recorded, so we will be posting this on our website. Anyone who registered today, I'll send a follow-up email that has the recording available to you, so you'll be able to watch it or share it with a friend if you want to pass that along. It'll be posted on the Mass General and the Estrella websites. I also wanted to let you know you'll be receiving an email after the sessions for an evaluation. So if you could just take a few minutes, it shouldn't take you too long, just to give us some feedback on how things went today so that we make sure that we are addressing your needs, and for future conferences, we know exactly what would be helpful to you. So if you have any questions, let us know in the Q&A feature. If there's any technical problems or you want to reach out, you can hit the chat box. And we're looking forward to 2 sessions today. And then at the end, we'll have our Q&A session. So now I'll turn it over to Alicia Estrella from the John Estrella Foundation for Cancer Research to do some additional introductions and give us some thoughts on the day.
Thank you, Laura. I would like to say hello to any newcomers and welcome back anyone who attended last year. We appreciate your returning. My name is Alicia Estrella. I'm the president of the John Estrella Foundation for Cancer Research. This foundation was started in memory of my dad, John Estrella, when he was diagnosed with renal cell carcinoma in the late 90s. They told us that there had been no new advances in treatments for kidney cancer in 25 years. This was a terrible thing to hear. My dad did participate in several clinical trials. We did get 3 additional years with him, which we wouldn't trade for anything. And so we decided to start the foundation to continue his pay it forward attitude. We are a 100% volunteer run organization. We've been in business for 19 years. This is our 19th year. We've raised over $300,000 to support kidney cancer research and the patients who are struggling with kidney cancer. We are launching our Helping Hands grants. These are small $1,000 grants for any families or patients who are need a little bit of help for something that your insurance is not covering. These grants are handed out on a rolling admission, so feel free to go to our website and fill out a grant form at any time, and we give out grants all year round until we run out of money. We're very happy and excited to be able to continue our partnership with MGH and support this webinar today. We hope that you find it helpful. We really appreciate you tuning in, and please give us any feedback so we can, improve it for next year if you're available. Thank you. Stop my share. And our first speaker tonight is going to be Lauren Baer. She is a senior genetic counselor at the Cancer Center for Cancer Risk Assessment at Massachusetts General Hospital Cancer Center. Her clinical work includes risk assessment and genetic counseling services in both the von Hippel-Lindau and familial renal cell cancer clinic, as well as the Hemangioblastoma Center with Dr. Othon Iliopoulos, as well as the breast and ovarian cancer clinical genetics at MGH. She's going to talk to us today about genetic counseling and kidney cancer. So thank you, Lauren.
Thanks, Alicia. And I just wanted to confirm that the view here looks okay to you.
Perfect.
Excellent. All right. Thank you so much. And so like she said, my name is Lauren Baer. I'm a genetic counselor at the MGH Cancer Center. I work with Dr. Othon Iliopoulos, who'll be speaking afterwards today. And today we're going to discuss genetic counseling and inherited kidney cancer. It's more of a review for patients and families. I realize many people in this audience have been through the genetic counseling and testing process, so hopefully this presentation is a helpful refresher about genetic testing and the implications on medical care, and can provide additional context when discussing inherited kidney cancer and testing with friends or family members. So thank you for your attention. I have no conflicts of interest to disclose today. And as far as my plan for today's talk, I'm going to start by giving an introduction to inherited kidney cancer. And I'm going to be using the term renal cell carcinoma, or RCC, throughout today's talk. And then we'll discuss the implications of genetic testing results on one's management and that of their family members, and then wrap up by discussing how to prepare for genetic counseling and some of the logistics that come along with it. Many of you are well aware, March is also Kidney Cancer Awareness Month, so I wanted to highlight that here as well. When we think about genetic counseling in the setting of renal cell carcinoma or kidney cancer in the family, it's important to have in mind what the goal is of genetic counseling and testing. And the goal is to answer the question, is there a hereditary cause for the cancer in the family? And specifically, genetic counseling and testing may help determine if you, meaning if someone who has had a kidney cancer diagnosis, if you're at risk for perhaps another kidney cancer or RCC, or if you're at risk for higher risk for another cancer type that we should design a screening plan for. It may aid medical providers in making treatment decisions for a current kidney cancer diagnosis, which Dr. Iliopoulos is going to talk about afterwards. And it will also, it may identify possibly at-risk family members. We talk a lot about how genetic testing can impact someone's own care, but it truly is a family affair given we share DNA with our family members. So genetic testing can have implications on people throughout your family tree. And that's just sort of what this picture is, the genetic family tree. And many times we're asked by both patients and providers alike, who should consider genetic counseling for inherited RCC or renal cell carcinoma risk? And some of the things we look for when making a referral is, if the person has had or has an RCC diagnosis, we look at their age of diagnosis. So if someone's age 46 or younger at the time of their diagnosis, that certainly we would recommend that would prompt a referral to genetic counseling. RCCs that have a hereditary cause tend to be diagnosed at younger than average ages. So anybody under that threshold should consider genetic counseling. Bilateral or multifocal tumors, or meaning if someone has kidney cancer in both kidneys or more than one tumor in their kidney, it's less common overall to see that. So it could suggest a hereditary cause, not definitive, but may prompt a referral to genetic counseling. If a person with RCC has one or more first or second degree relatives with RCC, so A first-degree relative is a sibling, parent, or child. Second-degree relative is one step further, so an aunt, uncle, grandparent, grandchild relationship. So anybody else in the close family with RCC, it again is less common to see that. So it raises the suspicion that there could be a gene in the family that may not be functioning and leading to an increased risk for kidney cancer. Certain uncommon types of RCC, the most common type of renal cell carcinoma is clear cell renal cell carcinoma. So some of the more rare histologies are a bit more likely to be hereditary overall. And there are additional features, non-cancerous features, that are maybe suggestive of a hereditary RCC syndrome. There are some benign dermatologic findings in some of these RCC syndromes, pulmonary findings like lung cysts, lung collapse, specific benign tumors of the brain and the spine, among other features. And these will be on the radar of oncologists and urologists, so that those in conjunction with an RCC diagnosis may prompt a referral to genetic counseling. And the most informative person to come and consider to meet with a genetic counselor and consider testing is someone who has had that cancer diagnosis, but they're not always available. They may have passed away, may not be interested in genetic testing, or it may be unavailable to them for a variety of reasons. And so it would be less it would be appropriate in that situation to see their close relative, maybe slightly less informative, but it would still be an appropriate referral to a genetic counselor if someone has a close relative who meets those criteria. And lastly, anybody with a family history of a known hereditary RCC syndrome or a positive genetic test result should certainly consider genetic counseling to discuss this further. How are inherited RCC syndromes diagnosed? So in most cases, this is by a genetic diagnosis, but on the next slide, I'm going to briefly touch on the clinical diagnosis, which is less common. A genetic diagnosis refers to a positive result on a genetic test, and the genetic test is usually performed on blood or saliva sample, which are equally as accurate to each other. Genetic testing, what it does is it assesses for changes in DNA, which we call these changes are mutations or pathogenic variants in a set of hereditary cancer genes. These are genes that we all are born with, and we have 2 copies of each of them. Our hereditary cancer genes help protect us from cancer. So if someone is born with a pathogenic variant or a mutation in one copy of one of these genes, their risk to develop kidney cancer is going to be elevated above the general population risk. About 4 to 5% of RCCs have an identifiable hereditary cause. So that means, most people with renal cell carcinoma will have a negative or a normal genetic test result, because overall, most RCCs, like most cancers, are sporadic or not inherited. So what we have here, this is a depiction of a blood sample. This is the tool we use for saliva sample. Again, they are equally as accurate in doing this analysis. A second much less common way to diagnose an inherited RCC syndrome is, like I mentioned, through the clinical diagnosis. If genetic testing is negative, in some cases, a clinical diagnosis may be established. Again, this is uncommon these days, but rarely a personal or family history can be highly suggestive of a hereditary syndrome. So despite a negative test result, they may still be followed closely for that hereditary syndrome. So some examples of this that have criteria that take into account the personal and family history are von Hippel-Lindau syndrome, Burkhawg Disease. They have genetic testing for them, but in the case of a negative result and highly suspicious features, a clinical diagnosis can be made in some instances. And I bring this up because there certainly are individuals and families under our care and maybe on the call today that have had negative genetic testing, but we still follow closely with a clinical diagnosis given the features in the person or in that family. So back to the genetic diagnosis. When a person presents to our clinic with a personal and or a family history of RCC, oftentimes our approach is to pursue genetic testing through something called a panel or a multi-gene panel. This here it's not an all-inclusive list, but it highlights some of the most well-established genes related to inherited RCC risk. A multi-gene panel is a way to analyze multiple genes at once and to cast a wider net to cover multiple hereditary RCC syndromes on one sample. This approach to testing wasn't available, say, 10 years ago. So it's becoming more and more common in our clinic. And it's useful because a diagnosis of RCC could be related to more than one hereditary syndrome. So this approach allows us to cast a broader net. I'm not going to go into this slide in a lot of detail, and this is not an all-inclusive list, like I said, but one other takeaway is that not all hereditary RCC syndromes or genes are associated with the same level of risk of RCC. No two syndromes are exactly alike. And cancer screening and medical management recommendations will differ between, based on the gene or the syndrome. Two people may say, I've tested positive on our RCC panel, but if they're in different genes, the management will be different. Once a multi-gene panel is performed, what are the possible test results? And this is all part of what we would discuss at a genetic counseling visit. And what do these results mean? The possible test results for hereditary RCC testing, and really any genetic testing, include 3 types of results. A negative result, we'll go through each, negative result, an inconclusive result, or a positive result. So we'll start with negative. If someone with RCC, they have or have had a diagnosis of RCC, and they pursue a multi-gene panel, let's say, and they have a negative test result, that means no pathogenic variants, no mutations were detected. This means the underlying cause of the RCC has not been established. The cancer may be sporadic, meaning it's not inherited, like most cancers are. Most of them are sporadic. Or it could be that kidney cancer is caused by some other gene that wasn't tested or we don't know about yet. So negative means no mutation was found. If someone with RCC or a personal history of RCC receives a positive result, this means there was a pathogenic variant detected in a specific gene, and provided that gene's linked to RCC risk, this would or could provide an explanation for the RCC diagnosis. This is certainly meaningful for the patient. It may impact their own screening and their own care. And it's also important for their family members. And we'll walk through an example in a few slides of how a positive test result can impact a person and their family. But there also exists a middle ground result, which is considered inconclusive, and it's what they call a variant of uncertain or unknown significance, or a VUS. A VUS represents a variant or a change in a gene that the lab isn't sure whether it impacts the function of the gene at this point, or if it's a completely benign finding, has nothing to do with cancer risk. The lab puts it in this question mark category. And the lab will work to reclassify this type of variant over time. So as they gather more data, as they test more people, they may figure out, well, actually, this is something that does impact cancer risk, and they'll call it a positive over time. But much, much, much more likely, these variants we eventually find out are benign. So we don't recommend taking any action on a variant of unknown significance in most cases, until we know conclusively which kind of bin it belongs in. So meeting with a genetic counselor will be really helpful in interpreting these results in conjunction with your personal and family history to ensure you're getting the appropriate follow-up. And that's, these variants are very common to find on these multi-gene panels. So we'd like to have a thorough discussion to make sure we're all on the same page. So what can genetic test results mean for family members? And like I said earlier, Dr. Iliopoulos is going to talk a little bit about how positive genetic test results can impact management of someone with RCC, but what about for the family? With a negative or a VUS result, like I mentioned, genetic testing is generally not recommended for close family members like children and these first-degree relatives. They may be candidates for renal imaging, so they may be candidates for screening for their abdomen based on the family history of kidney cancer, but not genetic testing in most cases. Other people may benefit from genetic testing depending on their own personal and family history. So if there's some other type of cancer in the family, but if we're trying to assess that person's immediate relatives, are they at risk for a gene, then their relative, if they've had negative testing, they don't need any testing in most cases. But again, we recommend discussing this with a genetic counselor to talk about who in the family needs genetic testing. What about for a positive result? If a positive result or a gene mutation is found in someone with RCC or in anyone, their first-degree relatives, remember that's parents, children, and siblings, each have a 50% chance that they also carry that same gene mutation. If that's the case, if they test positive, we'd recommend they have specific cancer screening and prevention strategies to reduce their risk for cancer. But they also have a 50% chance that each do not have the gene mutation. And that would mean they're likely at an average risk for cancer, and no special screening would be indicated. And again, we're going to go through an example of this, but we have these coins here because it truly is the flip of a coin, 50% whether someone carries it or 50% that they don't, if their close relative does. So why share test results with their family? We've touched on this, but we recommend individuals who are pursuing genetic testing to consider sharing their results with their family members, whether they're positive, negative, or inconclusive. We understand sometimes sharing medical history or genetic information, this could be a sensitive topic, but some reasons to consider sharing test results with family members are results can help relatives make informed decisions about whether they wish to have their own genetic testing. Results can also help relatives' healthcare providers determine if genetic testing is appropriate for that relative, and if so, which test would be most appropriate. Sharing test results may allow relatives to take steps to lower their risk for cancer or detect it at a more treatable stage. And sharing test results, on the other hand, it could also help relatives know that their risk for cancer is not elevated, and therefore extra cancer screening is not necessary. So it can have a significant impact on their relatives, really no matter what the results are. So let's demonstrate the implications of genetic counseling and testing with a hypothetical family history. What I have here is a pedigree or a family tree, and people, so females are circles and males are represented by squares, and anybody who's shaded in is someone who has had a cancer diagnosis with that type of cancer diagnosis and their age of diagnosis written underneath. People on this webinar may recall creating this with a genetic counselor prior to or around the time of testing. And so to help determine what testing may be indicated. Genetic counselors use this tool to kind of get a bird's eye view of the family to say, is there a pattern I'm seeing in this family and what testing might be most appropriate? So let's start with Jane. She's 55 years old and she's been referred to genetic counseling by her urologist. She was referred because she was diagnosed with renal cell carcinoma, a papillary renal cell carcinoma at age 45. So she has a young age of diagnosis. That's one of the criteria we look for. There's no cancer on her father's side of the family. Her brother has never had cancer. Her children don't have cancer, but her mother also had a papillary renal cell carcinoma at age 60. Grandmother, sorry, this got cut off here, but grandmother had an unknown type of cancer. No one knew what type, but they think it was possibly originating in the kidney, but we don't have conclusive documentation. So Jane's been referred because of her young age of diagnosis at 45, and her family history of kidney cancer. She meets with a genetic counselor. They construct this family tree and discuss the option of a multi-gene panel, and she decides to proceed with this multi-gene panel through a saliva sample. And after a few weeks, we get the results, and she's tested positive for a pathogenic variant or a mutation in the FH gene. And the FH gene is associated with a condition called hereditary leiomyomatosis and RCC syndrome, HLRCC. So that confirms a diagnosis for Jane of this hereditary renal cell predisposition syndrome. So what now? People on the webinar may be very well familiar. HLRCC syndrome is related to an increased risk for RCC, or kidney cancer, uterine fibroids in females, and skin fibroids in males and females. I want to emphasize not all genetic conditions are related to fibroids in this way. This is specific to HLRCC. So for Jane, with the diagnosis of HLRCC, we recommend she continue having imaging of her kidneys for any additional risk for another RCC potentially, either in the same kidney or in the opposite kidney. We recommend she inform her gynecology team of the higher risk for uterine fibroids. She reports she has had uterine fibroids in the past. And she's already having skin exams with her dermatologist, certainly continue those, and to evaluate for these skin fibroids. Skin fibroids are benign, but it's important that a dermatologist monitor them over time. So there's a very, very, very rare chance that they could turn into something called a sarcoma. So making sure that the dermatologist stays on top of that. Again, these recommendations will vary based on test results. Not all the hereditary RCC syndromes are managed the same way. So for Jane's care, there are now other parts of the body we recommend she have monitoring for outside of her kidneys, as well as continuing this close kidney cancer surveillance. How do these results impact Jane's family members? If you remember, these genes are inherited through generations. So given she shares DNA with her biological relatives, her family members are at risk for carrying this genetic variant as well. Her children, remember the first degree relatives, children, brother, and parents each have a 50% chance of also having the FH gene pathogenic variant and having HLRCC syndrome as well. We recommend Jane share these results with their family so they can consider genetic counseling and to discuss the option of testing. Remember, if a family member also tests positive, we recommend the same approach Jane is taking with the imaging of the kidneys, skin exams, and gynecologic exams. And if a family member tests negative, additional screening would not be indicated for that person. That's considered being a true negative if they do not have the FH gene variant. So her family members pursue genetic counseling and testing, and we'll start with her parents. Her father tests negative for the variant. He does not have HLRCC. He's at an average risk for kidney cancer. Her mother tests positive, which seems unsurprising given she also has had the same type of kidney cancer herself, but it's important for her mom's care and for her mom's brother. Now we know he is at a 50% risk that he could have this condition as well. This is Jane's uncle. Jane's brother tests negative. He does not have HLRCC, and his daughter, so Jane's niece, does not need genetic testing for this. It does not skip generations. And then when we think about Jane's children, her son has tested positive, and he also now has HLRCC syndrome. We recommend he begin abdominal imaging for RCC risk, have annual skin exams, and her daughter has tested negative. So no additional screening is required or recommended, I should say. So this is what we call cascade testing, which means testing family members once a positive test result is found, offering testing to all the relatives in the family. So this is a case where the risk factor for RCC has been identified through a genetic test. And we were able to determine which family members are at this higher risk and need screening and which family members are at average risk and don't require the heightened screening. So it's all about identifying potential risk factors in families. So just to wrap up, to think about if you have a genetic counseling appointment scheduled, or if you're thinking about booking one, or if you're talking to a family member about booking one, some of the ways to prepare for a visit would be to gather personal and family history information. So cancer diagnoses for yourself from family members, age of diagnosis, type of cancer, current age or age of death of a relative, any benign tumors, dermatologic lesions. As we've alluded to, some hereditary syndromes are related to benign lesions. And if there's been any genetic testing already performed in the family. Some individuals have found it helpful to discuss the visit with family members before you meet with the genetic counselor, to open up this conversation, to say, listen, I'm meeting with a specialist to talk about the option of genetic testing. Is this information you want to learn, or how can we make a plan to talk about these results together? What would be the best way for me to share this with you? Some people I've met in the past have really found that to be a helpful approach. And on the more logistics side, sometimes it's helpful to reach out to your insurance to determine if your insurance covers genetic counseling, the appointment itself. When you meet the genetic counselor, they'll talk about whether insurance will cover your testing, or kind of the logistics around the actual test coverage. But before the visit, you could always ask your insurance provider, is genetic counseling a covered service? Some last logistics around genetic counseling and testing. Genetic counseling sessions, they usually run between 30 and 45 minutes to go over the full family history. They can be in person or virtual. Certainly during the COVID-19 pandemic, we've had a big shift towards a lot more virtual care. This may be clinic and state dependent, but many places offer both options. As far as sample submission, how do we do the testing? We talked about that, blood and saliva. We can do at-home saliva tests, especially if there's a virtual meeting or a clinic blood draw. Again, they're equally as accurate to each other. Once the sample is received by the laboratory, analysis takes about 2 to 4 weeks, depending on the test. And again, insurance coverage, you'll discuss it with a genetic counselor. This differs based on insurance carrier. And these labs, they're third-party labs. They're not all, some testing is done in-house, but for most commercial laboratories, they have a policy where they would notify the patient if the out-of-pocket cost is greater than, some labs say $100, some say they'll notify you if it's any amount of money. Every lab is a little bit different. But some labs also have a direct pay option, that if insurance doesn't cover it, or if you want to go forward with testing if your insurance won't cover it for whatever reason, some labs offer it for a $250 flat fee. So just things to keep in mind, and certainly can discuss with a genetic counselor. In the interest of time, I'm not going to go through all of these resources, but they are here. The genetic this is our direct line for the Cancer Center for Cancer Risk Assessment, our genetic counselors at the MGH Cancer Center. Most local cancer centers will have access to genetic counseling. There's a helpful resource through the National Society of Genetic Counselors, and lots of different things that we're more than happy to help direct you towards those. And in summary, as we've talked about throughout, genetic counseling and testing can be useful tools in determining if the cancer in the family is hereditary. Test results can have implications on an individual and their family, but genetic counselors, we're here to help. This is our group of genetic counselors at the MGH Cancer Center. This is from pre-COVID times, so our team has grown significantly. Here, I want to highlight Margaret Emmett and Kathleen Steinberg, who shared some of their slides for this talk today. But overall, our group, we're in many, many different clinics in the hospital. I'm, not just kidney cancer, we're in breast and ovarian genetics, GI genetics. We're all over the place. So we're here to help if questions do come up. But I will I think we're taking questions after Dr. Iliopoulos' talk, but I wanted to take this time to thank you for your attention.
Thank you, Lauren. That was great. That was really informative and helpful, I found. Our second talk today is going to be by Dr. Othon Iliopoulos. He's a physician scientist, board certified in internal medicine and clinical oncology. He is an associate professor of medicine at Harvard Medical School. He directs the Von Hippel-Lindau and Hereditary Renal Cell Carcinoma Clinic, as well as the Hemangioblastoma Center, both at MGH, which provide comprehensive medical care to patients and families with hereditary kidney cancer syndromes. The Mass General Hospital VHL Clinic is also recognized as a comprehensive clinical care center by the Von Hippel-Lindau Alliance. Dr. Iliopoulos' laboratory at MGH Cancer Center studies how cancer cells adapt their respiration and metabolism to the environment to outgrow normal cells. His goal is to discover novel and effective methods to treat renal cancer and hemangioblastomas. He is the principal investigator in clinical research trials that are based on his findings in his laboratory. Dr. Iliopoulos is also a member of the VHL Alliance Board and the chair of their Clinical Advisory Board. Thank you for giving us your time tonight.
Hello, good evening, everyone. Can you see my slide in the presentation mode?
Yep, it looks good.
Okay, great, thank you. So thank you for having me here and inviting me back for this presentation. It's a pleasure and it's also very fun. I have to say, following the presentation of Laura is an outstanding member of our team. I am essentially very lucky to work shoulder by shoulder with her in diagnosing and treating VHL patients. She really kind of is an extremely graceful clinician with unbelievable relations with patients. And I loved her presentation. So I'm going to talk about a little bit the clinical picture of hereditary cancers, the treatment approach that we have. And I'm starting by telling you, or showing you these two nice pictures, which are not having direct clinical consequences, but I'm very proud of them. This is a 12 years old, now 13 years old, that I met from Lexington High, who used tweezers candy sticks to create an edible double helix of DNA here on the left. And on the right, she cooked a cell. She cooked an edible cell. The red part is the nucleus. The blue part is the Golgi apparatus. And these small cookies with the frosted cream on the top are the mitochondria, and there are further details of this. So Mary Ellen is a talented young kid that I am emotionally touched when I meet, because I think that either way, either she will become a culinary leader par excellence or an amazing investigator in the field of biology. So having said this, let me tell you how we're going to talk today. We're going to give you a short description of the most common hereditary renal cell carcinomas. I will refer to them as an HRCC, and these are essentially the principal ones that Lauren presented in her talk. We'll talk how we do surveillance from the practical point of view from these different forms of hereditary renal cell carcinomas. We'll talk about developments, and there are amazing developments in the treatment of hereditary renal cell carcinomas and approach. And I'll take the 3 moments of vanity in the end to talk about the work that we're doing in our lab and how that, I think, contributes and transforms the field of renal cell carcinoma that I'm very proud about. So this is a list of renal cell carcinomas and of hereditary renal cell carcinomas. Lauren talked about this list. I just want to let you know that one very important correlation exists between the histologic type of these tumors and the type of the gene, which is mutated, has this pathogenic change in the germline. So when we, for example, hear that the patient had clear cell carcinoma, we think immediately of VHL, or in other words, we can think of other diseases too. But if the patient does not have a clear cell carcinoma, most likely by 99% does not have a VHL disease. So when you bring the information for the genetic counseling, the physician of the family history, it would be, if available, to bring also the information about the specific histologic type of the tumor that the patient or the relatives had developed. So let me go with a short description of some of these diseases, and I'm sure that the audience, most of the audience, people who should probably have some of this or have some of these lesions, they would be very familiar. The people that we see that the most prevalent are the people that they have VHL disease, and the most common lesion in the people with the VHL disease, the hemangioblastomas, which are not cancerous, they're benign tumors that they develop in the brain or in the spine or in the retina of the eyes. Less common, but as you see, 50 to 6% of the patients do have it, is the renal cell carcinoma. So the sickness and morbidity of this disease is driven by hemangioblastomas and renal cell carcinomas, and to a much lesser extent by pheochromocytomas, which is benign or potentially malignant lesions that they develop in the adrenal glands, the small endocrine glands we have on the top of the kidneys that they produce the adrenaline in our body, and islet cell tumors of the pancreas. These islet cell tumors also are very slowly developing tumors that they can be malignant. VHL has no relation with pancreatic adenocarcinoma, the common variety that you hear, cancer of the pancreas. These pancreatic islet cell tumors are coming from totally different cells, and they're much, much less threatening than the classic pancreatic adenocarcinoma. So the other two diseases that are characterized by high risk for renal cell carcinoma and melanoma, that's why I group them together as the patients that they have a BAP1 germline mutation and the patients they have a mutation, the MITF gene. Their risk for renal cell carcinoma is not running as high as the VHL. They have a limited risk for renal cell carcinoma, but despite this, they warrant to be surveilled and detect these lesions when they're very early in their development. The things that we pay much more attention than the renal cell carcinoma to this population is the melanoma that can develop in the skin, or in the case of BAP1, can also develop in the eye for very specialized cells that they are like these melanotic cells in the skin. And that's why they need very early and very often ophthalmologic examinations. A third group of diseases is created by germline mutations in what is called succinate dehydrogenase gene. These are genes that they live in the mitochondria, and they have to do with the respiration in the mitochondria. They also have to do with the progression of their metabolites. Essentially, they're very close to the engine that produces energy and building blocks in the cells. The people that they have succinate dehydrogenase mutation can develop renal cell carcinoma. That's why we're talking about these mutations today. On the top of it, though, they can also develop gastrointestinal stromal tumors. They're called GIST, or pheochromocytomas and paragangliomas. Paragangliomas are tumors that they develop from the same type of cells that they give pheochromocytoma in these small endocrine organs, the adrenals on the top of the kidney, but the paragangliomas are extra-adrenal type of pheochromocytomas. The same type of cells live in our nervous system, and they may develop tumors in the neck or tumors in the abdomen primarily. Not all the mutations have the same diagnosis. We know that some are better players than the others, and the prognosis, like the possibility to develop any of these lesions and the aggression of the tumor, depends on the specific subunit, and people that they have mutations, the subunit B, have more aggressive tumors than D, than C, or than A. So it goes from more aggressive to much less aggressive and benign as it goes from B to D to C and the A. Next category is the disease that Lauren already talked about, which is the hereditary leiomyomatosis and renal cell carcinoma. These patients have a mutation in the fumarate hydratase gene. Fumarate hydratase gene also lives along with the succinate dehydrogenases in the mitochondria. It's kind of it's involved in a chain reaction to produce energy with the fumarate with the succinate dehydrogenase. That's why jokingly sometimes we say that the renal cell carcinoma is a metabolic disease of the mitochondria, and this is true. It's not a joke. So they create specific histology tumors. They are called papillary, but papillary type 2 specifically tumors. And these patients with a pathogenic mutation, they run a risk from 5% to 40%, 5% to 3%. The jury is still out of this. In the possibility of developing renal cell carcinomas. They also have, as Lauren presented nicely, uterine fibroids and skin fibroids that they're called leiomyomas. These are these red cherry bumps, elevation, like salmon type, not cherry, salmon type elevations in the skin. Sometimes they're tender, sometimes they're not tender. And also, like the succinate dehydrogenase, because they live very close to this chain of energy production, these patients also have the possibility to develop paragangliomas and pheochromocytomas. So all these are lesions that we put under surveillance once we know the patient has a specific mutation. And the last group I want to talk about, not because it's the last group, but because these are forming the majority of the patients that we see in the clinic, is the people that they have a Burkhawg disease. And these people have a mutation in a gene that took its name from the specific skin lesions they have. You see here that these lesions in the skin are different from the leiomyomas. They are not salmon-like. They don't look that angry. They are sometimes gone completely unnoticed, like small bumps that they cover the nose and the cheeks, and they're coming from the root of the hair, and they're called fibrofolliculomas, and that's why the gene was called folliculin. These patients have also cysts in the lungs, and sometimes these cysts can burst spontaneously, meaning without any type of trauma, and then the lung collapse, and this collapse of the lung is called pneumothorax. Now, I told you before with the other diseases that they form specific the type of histology, like the VHL gives you clear cell tumors, the BAP1, the MITF gives you atypical clear cell tumors, or a little bit papillary tumors. The fumarate hydratase creates papillary type 2 tumors specifically. The folliculin gene, when it is damaged, it can create any type of tumors. Chromophobe, oncocytic, only chromophobe, papillary, clear cell, and usually creates a mixture of everything. So the most often the reports that we read from the pathologist is this is a renal cell carcinoma in a relatively young person, but I don't know what type of histology this tumor is. I don't know how to categorize this clear cell carcinoma, this renal cell carcinoma. In this case, I say, I know how to categorize it as Burkhawg disease. So how do we do, let's say that we make the diagnosis, and having been aware of this type of lesions, what type of surveillance we recommend for all these hereditary forms of renal carcinoma? Again, remember, the surveillance has a goal to detect a lesion in a very early stage, so we can interfere this lesion either with a medication or surgically and prevent the local growth, the local extension and, more than anything else, prevent the metastasis of these lesions in other organs. So we look at the tissues that they develop these tumors. And the second rule of surveillance is, when do we start looking at the tissues that develop these tumors? We start looking at these tissues around the time that we know that these tumors may develop in the specific tissue. So, for example, in VHL disease, we know that an 8 years old, 10 years old kid does not stand any chance to develop renal cell carcinoma. When does the risk go up? When do we start seeing these renal cell carcinomas? At the age of 15, the earliest. And that's why we recommend starting looking at the abdomen at the age of 15. So, whom do we refer for in our clinic at the MGA? It's either the HRRCC clinic or the hemangioblastoma clinic. I think that Lauren covered that in much more better detail and granularity, but going through it very quickly. Anybody who has a personal or family history of HRRCC disease, any patient that has 2 HRRCC associated lesions. And when I say 2 HCC associated lesions, I mean renal cell carcinoma or 2 renal cell carcinomas, or renal cell carcinoma plus one of the other lesions in the skin, in the lung, in the brain that we mentioned before. Any patient who has a pheochromocytoma or paraganglioma, even a single pheochromocytoma or paraganglioma, needs to be tested, because the representation of inherited forms of pheochromocytoma, paraganglioma, even a single lesion, is very high, the same way that any woman that has an ovarian cancer is tested for BRCA1 and BRCA2 mutations, because the possibility is significantly high. Any patient who has even a single lesion of hemangioblastoma, because again, hemangioblastomas are very rare tumors, and a lot of people have an underlying mutation in the VHL, any patient with a pancreatic neuroendocrine tumor, and definitely any patient with spontaneous pneumothorax. The reason for this is that the lesion that the patient presents with, or the tumor, may be a single lesion. The whole panel of the phenotype of the disease might not have blossomed and developed yet, but this early single lesion gives us the clue that the patient may have a problem. So what do we do? When is the best way to start looking for things, and therefore the best way to test somebody? We want to test some person, so we know that we need to initiate the surveillance or not initiate the surveillance. So when do we do the genetic testing for VHL? We do it at birth, because they may develop hemangioblastomas in the retina few months old. What's the best age to do genetic testing for folliculin? Around 15 years old. And the reason for this is that the earliest ever detection that we had at the MGH, and we published it, and actually it's been referred in the literature, was a young girl of 15 years old that had a sizable tumor, renal cell carcinoma tumor. And for BAP1 succinate patients and MITF patients, when they're 8 years old, we do the genetic testing. We do the genetic testing, but then you want to ask the question, because this is a conference about renal cell carcinoma, when do we start specifically image the abdomen for renal cell carcinoma? I would make it very simple for you: when the kids are 15 years old. In all of these cases. So why do we test someone who is 80 years old, since we're going to start looking when they're 15 years old? Well, because they may develop melanoma in these 2 cases. They may develop paraganglioma or pediatric gastrointestinal stromal tumor in the cases of the succinate dehydrogenases. And we want to look for these lesions and keep an eye on these lesions before even we look for renal cell carcinoma. So this is the algorithm for the VHL. At birth or until the kid is 1 year old, we initiate genetic testing and annual retinal exam. Around 9 or 10 years old, they have the tendency, or they may develop hemangioblastomas of the brain and the spine, and that's why we do MRIs of the brain and the spine. And when they approach 14 or 16 years old, we initiate the annual MRIs of the abdomen. And depending on the type of the mutation we have, we always look at the blood for metanephris and catecholamines, which indicate the presence of a pheochromocytoma. People ask very often some questions that they show concern around this practice of the surveillance, and I want to address them now, and I'm happy to address them again if they come up in the questions. What is the safety of these agents that we give, the contrast agents we give for the MRI? Patients sometimes are worried a lot about the cause of a harm if they do so frequent MRIs and from the contrast agent. MRIs are not radiating the patients. They don't have radiation in contrast to the CAT scans, but do these agents that we put in the blood get out of the vessels and they sit in the tissues? And because there has been some concern about it. So let me put you at ease with this question. There is two types of contrast, MRI contrast dyes. The old-fashioned and more of the kind of the new fashion. The old-fashioned were the linear ones, and they are pretty safe, but there was some evidence that if your kidneys don't work very well, they may kind of ooze out of the blood and burn the skin. Very, very, very rarely. The second, more newest generation of the macrocyclic, the circular type of agents do not extravasate out of the vessels. They don't get out of the vessels, and people consider them, radiologists consider them very safe. So there is not a safety problem, in my opinion, for having often MRIs with the new generation of the agents. What does pregnancy do to my VHL tumors? This is a question that we hear very often. The truth is, I cannot support an answer one way or the other, because there are studies that they have been very controversial with a small number of patients or bigger number of patients, and they indicated, some of them, that there is no effect of the pregnancy on the tumors. Some others said that it has an effect and the tumors grow faster. I think the data is conflicting. In my personal opinion and experience from many patients that I saw becoming pregnant in our clinic, I'm not convinced that the tumor growth is affected by the pregnancy significantly. Can I be breastfeeding and use an MRI? The answer with dye, the answer is absolutely yes. We don't do MRIs in the first trimester with dye in mothers that are pregnant. We try to avoid any type of imaging, MRIs with no contrast, even if the mother is, even without contrast when the mother is pregnant. There is no evidence that if we do an MRI without the contrast, without the dye, that causes any problem to the fetus, but people get over conservative and sensitive, and very correctly, and they try to avoid the MRIs. Once the baby is delivered, there is no problem with the MRIs. Practically, the gadolinium that you get in the vessels does not go into the milk. And if a little bit of what goes to the milk, 0.04%, is not absorbed by the intestine of the baby. Again, out of an abundance of caution, we say bank milk, freeze milk the day before, and just don't feed the baby, don't nurse the baby for 1 day. New treatments for renal cell carcinomas. Is some very important distinction that I have referred to. All the tumors don't grow with the same speed, all the type of tumors. Some tumors having more benign behavior, and these good players are the tumors of the VHL and the tumors that develop in patients that they have Burkhawg disease. In the patients with VHL, for many years we applied the rule of 3 centimeters. If the tumor doesn't arrive at 3 centimeters, we don't touch it. And you're going to say, why don't we touch it? Why don't we take it out? Well, we don't take it out because we expect that the patient may have many tumors over many years. And if we start taking them out, at some point, the kidney function, because it's damaged a little bit, even with the best techniques, is going to decline over the years, and we don't want to end up in dialysis. The BHD tumors have even better behavior than the VHL tumors. And when I say better behavior, I mean they don't tend to metastasize and they don't grow fast. So we apply also the 3 centimeters, although silently, people sometimes are very relaxed about it and let them go a little bit more above 3 centimeters. There are some other, though, tumors that they are kind of the bad players, and we try to remove these tumors immediately. The worst player is the tumors developing the patients with fumarate hydratase mutation. These are the tumors of the HLRCC syndrome disease. Even we see the smallest evidence, we remove it immediately because these are aggressive tumors. They can go from 5 miles per hour to 100 miles per hour in a class of a second. SDH, BAP1, and MITF, we don't have very strong evidence that they are as bad as fumarate hydratates. In other words, they don't appear to be as bad as fumarate hydratates, but we're all cautious and remove them early. So the 3 centimeter rule does not apply for this type of tumors. The treatment of kidney cancer, the localized kidney cancer, I'm not talking about the metastatic one, moved a lot through different decades in VHL or other hereditary renal cell carcinoma patients, and essentially it had revolutionized, it went a tremendous paradigm shift this year. So back at the 80s, people were removing the kidney and people were actually not dying from the disease, but they were dying from complications of dialysis. The early 200s, people observed the tumor. At 210, we established the rule that we don't touch anything which is less than 3 centimeters. And then people started just doing, picking up the tumor by enucleation or zapping the tumor with radiofrequency ablation or doing cryoablation. All this is still in true, and all this is still practices that we follow these days. But now we have a new player that shifts the landscape, although we don't know how to use this player very, very accurately. Is a new oral medication that inhibits the HIF2 alpha protein, that it is actually the protein that drives the growth of a renal cell carcinoma in the VHL negative tumors. And this agent has been approved by FDA for patients for the VHL disease, hasn't been approved for any other disease, not even for sporadic renal cell carcinoma. It's been approved first for VHL patients in August of this year. And of course, these were big news, a New England Journal of Medicine paper that we published, and it's a game changer. What is this HIF? This HIF is this protein in our cells. The VHL is, I used to present and say it's a vacuum cleaner. It's a vacuum cleaner that says that goes, finds all the HIFs and sucks them out of the cell. If the patients do not have the VHL, that means the vacuum cleaner is totally broken. This HIF1 goes rogue, and this HIF1 is a protein that goes to the nucleus of the cells and turns on genes, and the list of the genes that they are turned on makes the cell a cancerous cell. So if we could find a way to eliminate the activity of this HIF protein in the renal cell carcinomas that are VHL negative, we're all thought that this is going to be big news. And indeed, this is the case. MGH participated with a couple of other institutions in an international trial, which we entered VHL patients. These VHL patients were treated with this medication, 120 milligrams orally a day. And this medication does something that we were taught before from experiments in the lab, that this is very important. This HIF cannot act alone. It needs a partner in a crime, which is this other protein, ARNT. If these together, they are not engaged, if they don't talk to each other, essentially really stick to each other, they're neutralized. So this belzutifan is a very small chemical that goes and lodges between HIF2 alpha and ARNT, and essentially breaks this partnership apart, and therefore it stops the activation of the genes that the HIF1 turns on in the nucleus of the cell. And here you can see the left side left of the red arrow is the average growth of the tumor, individual renal cell carcinomas in VHL patients, about 3.5 millimeters every year over many years. And this is what happens to these same individual tumors after belzutifan treatment initiates the patients. So lots of them are actually stopping growing and many of them decreasing. So the average, the median linear growth was 3.5 millimeters, and now the median shrinkage of the tumors, the reduction of the tumors is 4.5 millimeters per year. So these patients have the tumors shrinking. They do not require nephrectomies. They don't require surgical interventions. And of course, that makes them to be, saves the kidneys and changes their life. The belzutifan doesn't only act on renal cell carcinomas, but it acts in a lesion that's even more difficult to access surgically, which is the hemangioblastomas of the brain. I have many patients that they went from one craniotomy to another craniotomy. The response rate for the hemangioblastoma tumors is about 64%. So again, this miracle drug, so to say, which is the outcome of 20 years, 25 years of work in the laboratories, changes the game for the treatment of patients with VHL. This is a patient that I treated very recently. She is a young VHL patient, and an adorable individual, a fighter who presented with headaches. It's a horrible situation. She could not eat with the almost 4 centimeters tumor in her brain. 6 weeks, only 6 weeks after treatment with belzutifan, the tumor became 26 millimeters, like 2.6 centimeters, and 12 weeks later, the tumor is 2.4 centimeters. She's off any other medication that was taken, steroids, pazopanib, anything else, and she's going back to work 3 months after the initiation of treatment without craniotomy. She had 3 of them prior to belzutifan treatment, 1 of them with complications. This medication is very benign. It's very well tolerated compared to any classic chemotherapy or other types of targeted therapy. This medication is doing very well. The only predictable in about 90% of the cases side effect is anemia, but anemia is something that can be dealt with. Most of the anemic patients have no symptoms. If they have symptoms, we can deal with the anemia. Is it a miracle drug? Maybe. We don't give it to pregnancy, to pregnant patients, because it causes abortion. And the only kind of a drawback is that we don't know the effect that you have on fertility. So I advise the patients to do sperm banking and oocyte freezing. We don't know for sure that it affects the fertility. There may be some evidence, experimental evidence from the mice, but definitely this is not something we want to test. It takes a lot of time to act, so you may take the medication for 6 months and then start seeing an effect after 6 months. Tumors may remain stable for many years, up to 3 years, and at some point we had very delayed complete responses and disappearance of the tumors after 3 years. Unfortunately, we have very, very few patients, fortunately very, very few patients, but unfortunately they have evidence of progression. I'm not going to go through this slide for the sake of time. I'm going to only say that we don't know how to use this medication. We know we have a medication. This is a new toy. This is not to spread in everybody who has VHL disease. We don't use it for prevention, and we have to do studies to find out what is the optimal use. Do we give it for lifetime? Do we give it for a while and then we stop it, the tumor disappears? Do we give it intermittently? Would we give it to a patient with only 1 tumor, and so on and so forth? So there are 2 trials going on right now. One of them is an international trial for advanced tumors. Pheos paragangliomas and neuroendocrine tumors of the pancreas, and we are actually have submitted to the IRB a trial for renal cell carcinoma and hemangioblastomas, the Mass General, in which we seek to understand what is the best use of this drug, dose and time-wise, in relation to the response of the tumor, so that we do not make the patients anemic and we essentially extract the most benefit out of it. The other disease that they're very good news is the fumarate hydratase disease. We don't have a drug like the belzutifan for localized disease, but since this is a very aggressive disease, many patients had escaped the localized status and they have metastatic disease. These fumarate hydratase negative tumors do not respond to the classic treatment of renal cell carcinoma, but the combination of erlotinib and bevacizumab. Erlotinib is an oral inhibitor of EGFR, and bevacizumab is an antibody that attack the vessels that feed the tumor, has amazing responses. In patients that they have HLRCC, 72 response rate. In patients that they have a sporadic, non-LCC related fumarate hydratase negative tumor, 35%. You can see here how tumors turn from positive to negative below this line. And here you see the survival, the historic outcome of a metastatic fumarate hydratase, not localized. It was quite scary, and patients that they are treated now this way with this combination of drugs, they live up to 4 or 5 years. Again, we like to take these lesions away as soon as we see them. I know that I went over the time. I will take very, very few minutes, like 2 minutes, to say about some more discoveries. I said this is the vanity probably of the investigator. I'm a physician scientist. I run the hemangioblastoma clinic and the HRCC clinic, but also I run a lab. We discover our own HIF2 alpha inhibitor that works in a different mechanism than the one that's in clinical trials. We bring it now to preclinical completion studies, and we hope to go to the clinic. And this is a homemade compound in our lab. This is a different mechanism, and maybe it can be used either in conjunction or for patients that they have resistance to the belzutifan. The lab spent a lot of time to study the metabolism. As Alicia said at the beginning, our discovery is that the VHL negative cells do not have the same metabolism with the normal cells, dramatically different metabolism. The normal cells eat glucose to grow. The RCC cells, the VHL negative, eat glutamine in order to go, and therefore we can target this enzyme that uses the glutamine and produces clinical responses. And the last kind of science cycle is slide is the one that tries to unlock the mysteries of the Burkhawg disease. We published from the lab that the way that folliculin works is that it has to do with the recycling of this red button here, which is a transmembrane receptor. This is a growth factor receptor. The cells grow because sense growth factors from the environment, and this red button here is where the growth factors goes and stick. So in the cells that they have folliculin, this growth factor is activated, tells the cells to grow, and then quickly goes to the lysosome and is chopped out and inactivated. In folliculin cells, it goes to the lysosome very slowly, and most of it goes back to the surface to repeat the cycle. So this is a cyclical thing that fires 10 or 100 times more than here, and that makes the cell to turn slowly malignant. And of course, there is many advances in the immunotherapy of renal cell carcinoma in the metastatic disease. We don't use immunotherapy right now in the localized disease of any of these tumors. Lauren talked about it, and I'm going to stop. I want to thank my lab for doing all this work these years. I want to say that we took clinical trials from the lab, like the glutaminase, the glutamine observation, to nationwide clinical trials in ovarian cancer, prostate cancer, and renal cell carcinoma. I want to thank Lauren for being a unbelievable partner that graced us with her presence in the clinic. And I want to also thank the Estrella Foundation for having me back. I want to say that we're fighting this battle along with all of you for brave patients. Our ability to fight this battle depends on money. This is a hard reality, and having people to rally behind us and give us their financial support and emotional support like the Estrella Foundation is doing, it's very important for us. That's it. I stop sharing my slides.
Thank you so much. That was amazing, smushed into a small amount of time. Appreciate all those updates and some of that great news of effectiveness of new treatments coming up. Can I hand the questions over to Susan?
Hey there. Hi. Thank you, Dr. Iliopoulos and Lauren. That was awesome. I always learn something from everyone. My name is Susan Hahn, and I actually am on the Estrella Foundation board with Alicia. And so thank you for those kind words. We're thrilled to be able to support the efforts at Mass General Hospital and to help support educational opportunities like this. So I'm going to start by going over questions. I don't see, if you have a question and you're wondering how do I do this, because I know that you know you're on mute, if you just toggle your mouse over the Zoom screen, you'll see a Q&A button at the bottom. If you click on that, you can type in a question. And I don't see any questions currently.
There's one in the chat.
I am looking, okay, hold on, let me look in the chat.
When did you start screening for HLRCC?
There you go. So then you just ask the question. So there you go.
I would start screening for HLRCC early. And when I mean early, I mean probably around 9 or 10. The reason is that we're not exactly sure about the earliest age of onset of renal cell carcinoma in general RCC, and these are aggressive tumors. So again, we want to start the game of surveillance early. The second reason is that the pheochromocytomas of the paragangliomas of the HLRCC may come before the renal cell carcinoma. Definitely young ladies that they go into puberty may develop early fibroids in their uterus. So we have seen patients that they had painful and very hemorrhagic periods right when they acquire their periods. So I think to be in the safe side, I would test again at the age of 8, 9. I don't know if Lauren has there is no guidelines, so Lauren may have a little bit of a different sense of this. No,
I think you're spot on. I think there was a report last year of a young onset RCC in the setting of HLRCC. So I think there were the general approaches similar to our clinic to start around between 8 and 10 to think about testing, just given some of these early. It's still really rare, like you say, for an RCC at such a young age, but because it's been reported, they recommend starting around that age.
There is another question that says, can you explain the differences in the types of VHL? I'll take it. So I want to break it in 2 types of questions. One of them is why some people develop certain tumors and they don't develop other tumors. So the only thing that we know is that there are 2 types of VHL mutations, the type 1 and the type 2, and there are different categories of mutations. The patients with type 1 develop renal cell carcinoma, angioblastoma, all the tumors except pheochromocytomas, paragangliomas. The type 2 may also develop pheochromocytomas and paragangliomas. This difference, we can explain it. It looks like the mutations in the first category destroy completely the protein. The mutations in the type 2 are more surgical, fine mutations, and instead of unfolding completely the protein, they may retain some function of the protein. And this retention of the some function of the protein is required to allow pheochromocytoma to develop. We're not exactly sure which is this function. But it doesn't appear that this is giving a new function to the protein. It's just destroying it, but not completely. The more difficult thing to address is the second part of this question, if you break it. And the second part is, can we explain why some people have lots of tumors, early tumors, and suffer, and some other people do not have? They have a little bit, they have one hemangioblastoma, one renal cell carcinoma, and the tumors appear in later age. So can we explain the aggression of the tumors? We can't. We all suspect that depends on the other genetic context that the mutation lives inside. Like we get the one VHL allele from dad and one from mom. One of them is mutated, but we get so many other genes from mother and father, and these do not go as all together. You can do an amazing mix and match of the genes that you get. So it appears that this background is the one that determines if you're going to have an aggressive disease or not. We're actually thinking of starting a international study, the MGH, to examine what is called polymorphism. Polymorphism is a change in the gene. Remember when Lauren said before, you have a bad gene, you have a good gene, or you don't know what you have. Some of these you don't know what you have, or even some of the good genes. It is writing a word, but with a different spelling. The word is pronounced the same, the protein function is preserved, but the spelling is different. Is the tomatoes versus tomatoes. And the tomatoes may be very bad and the tomatoes may be good. So if you live around tomatoes as a VHL gene, you may have a very aggressive disease. And if you live about tomatoes, you may have a non-aggressive disease. So that requires to screen a big number of patients and find all these different, not spelling errors, but spelling idiosyncrasies, and see if some of them determine when you have aggressive disease or not. It's a little bit painstaking study, requires a lot of manpower, but I think that we as genetics field and the tools for rapid genomic discoveries and interrogation of the sequence of the DNA brings us actually right now in the correct time to do this. And I believe it's going to be the next big question in VHL disease.
Great. So there is a question in the chat. So someone's wondering, they had, if somebody had renal cell carcinoma diagnosed in their kidneys about 17 years ago and had kidney ablation of both kidneys, and they're doing okay, but if their protein level is very high, 82, they're wondering what to do in this case. The
protein level, you mean in the urine? Probably the protein.
I'm assuming, yeah, because I only can work on what they type
in the urine.
Assuming.
I don't think that the protein urine is due to the ablation that they had 17 years ago. As long as the creatinine is good, it's not due to the ablations. Remember, besides having renal cell carcinoma, people may have a lot of other diseases that they affect the kidneys. We had a patient that he had many ablations, was doing very well, and then he caught a cold and his creatinine went to 5 from 1, because sometimes the immune system attacks our kidneys when we have a cold. So I think that this person should examine with a nephrologist the kidneys independently and determine what are the other factors that may affect the kidneys and take care of them. Okay.
Here's another question. This one might be for you, Lauren. So if somebody does have a pathogenic variant that's found that they inherited and they don't want to pass it on, is it possible to test the embryo for that, to do prenatal genetic testing?
Yes, it is. And I would certainly want to refer them to a prenatal or preconception genetic counselor to talk about the details. But yes, through IVF technology, or it is possible to essentially create an embryo like the regular IVF process, and then test each embryo for the pathogenic variant that the parent carries, and then proceeding with a pregnancy with an embryo that that does not carry that genetic variant. So that's certainly one option. The other option is, testing a pregnancy or testing a child right after birth. But yes, that's a long way of saying yes, it is a possibility. Yeah.
So it's interesting. I think a lot of people don't realize there's different types of genetic counselors out there too. So you'd see Lauren to work up your cancer. She's we refer to her lovingly as a cancer counselor. And then once you're worried about risk to future children, then you go see what we call a prenatal counselor who works in the pregnancy. So
absolutely, they're going to have the most up-to-date knowledge about it for sure. Yeah. But yes, it is possible.
Yeah, so there you go. So yep, and great, because Lauren can refer you there. So somebody asked in the chat, they wanted to know about Reed syndrome and the relevance to, I think they're saying family history or FH?
To FH, to fumarate hydratase. Okay. I answer this question for everybody in the chat. Reed syndrome is HLRCC.
Okay.
So it's the same mutation. So name was Reed's and now it's an HLRCC.
Okay, great. So then another question is, if somebody is adopted, so Lauren, you talked about like, oh, if there's like one lesion in a family history, you would test, but if you don't have a family history, you have 2 lesions, you test. What do you do in a situation where somebody's adopted? How does that change things?
Yeah, that's tricky. So having a limited family history is certainly something we can take into account. So we do in all the clinics of the Cancer Center, the breast, ovary, GI, we certainly meet with patients if they say, listen, I know I'm not diagnosed at 46 or younger, like our criteria are, but I don't know about my family history. We're more than happy. Well, we're happy to see anybody, but I think it's certainly having limited family history can be, well, limiting. And so it certainly could be indicated to pursue testing in that instance, taking into account as many factors as we have. So yeah, I think that's an important thing. I'll add that to my slides for next time, a limited family history.
There you go. And I think we're right at time, and there doesn't seem to be any other questions. So I think maybe I'll close us out and thank Lauren and Dr. Iliopoulos for that awesome presentation. I always enjoy it. And again, we're going to send you a survey. So make sure you fill that out. Tell us some topics that you might like for the next time that we do this. And any passing last words, Alicia, or anybody else that anyone wants to say?
Just appreciate everybody coming out. Hope you enjoyed the day. We really appreciate the time of Dr. Iliopoulos and Lauren. It is in the evening, and we do appreciate you coming out and participating with us. Thank you.
Well, thank you very much for having us. We really were inspired by this type of activities. If any of the people that they participated wants to reach out and ask questions about their personal health or health of the relatives that's related to HRRCC, we'll be happy to answer them. Our email is available to everybody.
Absolutely. I completely agree. Thank you all so much.
Wonderful. Thank you, everybody.
Bye-bye. Good night.